So starting on this note, we will be starting our talks. That is, we have a sessions by Dr. Nishanth, that is back to surface, perfecting the art of PRK, followed by Rushad, and then followed by the next talks. So Dr. Nishanth is over here. I'll hand over the mic to him.
Yeah, a very good morning to everyone present here. It's so nice to see after a banquet, people are here at 8 in the morning. So I'm going to actually go back in time. I'm sure that we all must have done a refractive surgery called a PRK, which must have been done. So the questions we actually had to ask ourselves is, yeah, so why PRK? So it was a painful procedure in those days, and the epithelial removal had to be done either by alcohol or PTK or by scraping. And I think we used to do one eye at a time. We used to do one eye, then patch the eye, wait for 3-4 days, wait for it to heal. The healing time was longer, and it was not allowed to do a lot of dioptric correction. But then, now we start to question, why not PRK? I'm sure that PRK is going to stay in the present, and it is also going to be the future compared to many refractive procedure, because it is not such a painful procedure with the advancements we have, and the epithelial removal has become touchless, is what I'm going to talk about, the trans PRK method. We do it bilateral because of the BCL which we are able to put, and very less healing time with more dioptric correction because of the use of mitomycin, and it is actually proved as one of the most safest refractive procedure. So what is the trans PRK? So we call it as actually a touchless procedure because I'm sure that both the epithelial removal and the dioptric correction both is done at the single go. So the ablation, so we know that the first picture is somewhat what the regular cornea is, and the refractive component and the epithelial component is corrected at the same time, and then the healing is also happening very quick. So we know that usually there are 5 steps which takes for a PRK, but I'm going to talk about the Schwinn machine which I have, no financial interest, but that's the machine which I use, and you have a single excimer laser step which corrects all the sequence. So this is how we actually have the data collection, which I'll talk to you in detail about what is all this about. So what is the smart surface technology? As I told you that the epithelial removal has become more advanced with time, where you know something called the Fullerene 3D model. Normally a PTK ablation happens with a flat surface. This smart surface technology is actually combined with the shape of how the cornea is supposed to be looked, and the amount of ablation is refractive neutral. So it is an amazing technology which is used by the Schwinn machine for removing the epithelium and correcting the stromal power at the same time. And it is usually ideal for all people who are actively into sports, who are athletes, and for some people who are actually in the government official where they're not supposed to be. Nowadays they say that you're not supposed to be found out that you have undergone a refractive procedure, for which I would do a trans PRK. We know that it is a one-step technique for the epithelium, and there are different methods you can use them as well, either an aberration-free or the wavefront guided method. So there is no alcohol required, and the best thing is there is no interruption. It is not like you do a PTK, you wait, because then the chances of epithelium become dry is more, so all this waiting time is reduced with this method. And the advantage is it is just one step. You have both the methods, no interruption, and faster healing process. And also the technology for the pupil tracking is amazing, because it is also not only X, Y, and all that. It is also when the patient is breathing very heavily, the movement of the eye which moves up and down is also taken care of. Normally in the Indian population, it is proved that we have an epithelial thickness of almost around 55 in the center, which goes towards 65 in the periphery. But according to literature, 70% of them, it shows that they have the epithelial thickness in the center. But I do have an anterior segment OCT in which I do an epithelial mapping for more precise thing. So I just told about the smart pulse technology and how it works compared to the flat surface. This is a high scanning electronic microscope. You can see the picture on the right is what is done by the trans-PRK, vis-a-vis the one on the left is what is done by a normal PRK method. So how do you calculate? So there are two different types. I can see the top left is the aberration-free method and the bottom right is the corneal wavefront guided method. So the epithelial thickness you can mark it from any machine. So this is taken from the MS39. You enter the subjective refraction over here, and all the other methods you can see that it can be either trans-PRK, PRK, LASIK, femto, or even a relift procedure. So once we choose the trans-PRK, the epithelial component is also incorporated in this. If you can see over here, the epithelial thickness shows 0 and the total ablation is 97. So that is why there is no two-step procedure. It combines and does it together. And here, what is the advantage in the wavefront guided treatment? You also have the higher order aberrations which is being corrected. That is why if you see that in the corneal wavefront guided, it is 101 of ablation, and here it is 97, because there is more amount of regularization which is happening due to the ablation of the higher order aberrations. The best thing is also the manager, where you have the Zernike polynomials in the corneal wavefront guided treatment. So you can try to cut off whatever aberration you want, either the coma, trefoil, all that can be done in the wavefront guided treatment. So this is actually just a live video which I've done of how we actually call it as a bladeless, touchless procedure. You see the debris removal which actually comes into place, and once we actually this is actually the beginning of the procedure, just not after preparing anything. So all I do is I just focus, and that's how I sit. So it is a purely touchless procedure. The epithelium is taken care of by the ablation. The stromal correction is also done. It is a wonderful procedure with a very fast healing process. We do also have studies where the epithelial remodeling in the trans-PRK is actually much faster than the conventional PRK. But yes, there is no, I'm not going to say any much differentiation between the outcome of the power. In cases of myopia, we keep an optic zone of 6.3, where we know that from the central epithelium, that is 55 microns, towards the periphery it goes to 65. But what about other conditions? I mean, in this the diameter, depth and the curvature is perfect. But what about other conditions where the diopter is different? So we can actually manipulate the optic zone as well. So normally, which we keep at around 6.3. As the diopter increases, you can see that the epithelial thickness is very important, because if you want to maintain the same optic zone of 6.3, you have to manipulate the epithelial thickness if it is required. Otherwise, I mean, so basically what I'm trying to say is make sure that the epithelial thickness and the optic zone, you are able to match it according to how you want. Otherwise, if the epithelium is little thinner, the amount of ablation which happens if the epithelium is going to be thick is going to be more. That means that only without ablating only the epithelium, you might ablate some amount of stroma as well if the epithelium is very thin. And if the epithelium is thicker than what you have actually indented, you are actually going to start ablating the epithelium, where the machine is going to think that that is the power correction. So please make sure that you have an AIOS2025 to decide the epithelial mapping. The best is also used for retreatments. Actually, I do the corneal wavefront guided for any retreatment. Even for post-keratoplasties, we can do post-cataract surgery, refractive surprises, and for any residual power, I use the corneal wavefront guided for the retreatment method. So this is zone selection, which I was talking in terms of how the power is done. And the final take-home message will be a one-step treatment. It's a no-touch technique, very fast epithelial healing, no flap or incision, and it's very perfect for myopic treatments. Thank you so much.
Thank you, Dr. Nishanth. Excellent presentation. One question for you is, are there any case scenarios where you would choose maybe a conventional manual debridement of epithelium over trans-PRK?
Yeah, so if we don't have an epithelial mapping, so why I prefer the manual debridement is sometimes in cases of keratoconus when I'm trying to do the trek. So we know that the epithelium is not constant even a millimeter from each other. It's not a gradual thing. So there I remove manually. And apart from that, for if as long as you have the epithelial mapping, you can always enter it. If you don't have epithelial mapping and the power diopter is less than 1.5, I manually prefer.
I think the epithelial mapping is the key, because sometimes you get islands which are of thicker epithelium or thinner epithelium, and then it's not a uniform removal. If you're doing a trans, then it's better to go with a manual only in those
Correct,
cases.
correct. But does it make a difference in terms of higher power of more than 3 or so by keeping a standard at 55?
So I'm not very sure, but when you see that on the epithelial map, then you're tempted. I've had a few scenarios where I've changed my plan from a transepithelial to a conventional because of having an epithelium that's irregular. Epithelium tends to be quite dynamic, so at times you can get that, and you may have to change your plan. Dr. Audrey, would you like to?
I would say especially after retreatments, you know, if you have previous, if you're doing a ablation and you have a previous refractive treatment, then you're going to most likely have a thicker epithelium, and you have to be really quite careful, I would say, with this, just because of, you know, what of course has been mentioned. And I did a bunch of trans-epi PRK in the past, and I actually have gone back to just manual ablation because I feel that it's more accurate in a sense of knowing exactly where you are. Of
Even
course,
with the epithelial mapping?
well, yeah, I mean, if you have the epithelial mapping and everything looks absolutely pristine and it's not a, you know, retreatment of sorts, then I think it's all right. I'm not a huge I don't do a lot of PRK. I'm actually not a huge PRK fan. I know that will go against a lot of what other people do. However, I use it mostly for enhancements, and that's probably why.